That might be me.
Hello, everyone, and a warm. Oh, I love that the room collectively looked at the laptop. Is it off now? Great. Hello, everyone, and a warm welcome to our Health and Adult Social Services Standing Scrutiny panel. This is the final meeting of the civic year. We are holding the meeting, as you can see, in hybrid format. And we are expecting some members and officers to join online. We're live streaming on YouTube, so it is accessible to the public. Just remind members and officers who are online to be on mute. And obviously, if we can keep the volume muted in the room as well, that would be grand. Those that are online, if you can just use the raise hand icon if you wish to speak. I think in terms of councillors, we're expecting Councillor Kim Nagpal online, so that's great. And Anna Marie's just confirmed that she is there. Apologies for absence. I have received apologies from Councillor Kate Crawford and Councillor Kamaljit Dinsa. I've also received apologies from Kerry Stevens, our Strategic Director for Adult Social Care and Public Health. Kerry has attended all of the other meetings, so we decided it might be good to give him a break this evening, and Anna is leading on many of the other items. Item 2 is urgent matters. I have no urgent matters. Item 3 is matters to be considered in private. There are no matters to be considered in private this evening. So we move to item 4, which is declarations of interest. As usual, I am just declaring that I'm employed by the Nursing and Midwifery Council. Councillor Conti.
Yeah, I'm a GP in Hounslow.
Any other declarations of interest from panel members? No. In which case, I'm then moving on to the minutes of the meeting held on the 19th of March. Are we happy that they are accurate, Councillor Conti?
There's just one thing in the minute. At the end of the meeting, we had a discussion, I think it was led by Councillor Crawford, about the care line closure. And I think she expressed sort of concern about it and the fact that a paper should have come to the panel before that. And I think that's documented in the minutes. I think that would probably be a good thing to have in there.
Sure. So in terms of the care line itself, because it wasn't an agenda item on the minutes, I've been informed by Democratic Services that it shouldn't be recorded, but Councillor Crawford does know that if she wishes to request the report, that she can contact Helen Harris. So it's because it wasn't an agenda item that it doesn't appear in the minutes. But I don't know, Anna Marie, if you want to add anything to that. Let's use our mics. Councillor Steed.
Picking up on Councillor Conti's point, it is an issue that has aroused a lot of controversy, and I know it was not it was an officer-led decision because it wasn't a statutory duty. Or I think it would be a positive thing that if we could actually have some official paper from the officers concerned, and I know the issue also is to do with housing and to do with adult social services. So I appreciate the slight complexity potentially of that, but I think it would be a helpful thing.
I think we can definitely bring forward a paper as part of the work programme for next year. So I'm happy for us to take that away as part of the work programme planning, if that's okay. So we'll move on then. Sorry, I should just get, are we happy with the minutes other than that issue that's been expressed? Great. So we'll move on to dental care access, which is our first substantive item. So I'm going to pass over to Dr. VJ Taylor. We're very pleased to have Jeremy Woolman, the Head of Primary Care Commissioning for Dentistry, Optometry and Pharmacy, with us this evening as well. We've got about 10 minutes for the presentation, and then we'll open it up to the panel for questions. So, Dr. Taylor, if I pass over to you in the first instance.
Thanks a lot, Chair, and good evening, everyone. And first of all, I just want to say, thanks to the Scrutiny Committee for allowing us the opportunity to talk about dentistry, because it's clearly a very essential part of primary care health provision and healing, and in North West London. Jeremy Woolman and I've got Kelly Nizzer on the call, who are going to lead the presentation and will also support some of the questions from the panel. So I'm going to hand over to both of them, and I also have Dr. Noor Sakor, who's a local dentist, who's also one of the clinical leads for the local dental committee, who's here to support in terms of any of the questions that arise.
Thanks. Evening, everybody. So again, nice to be able to come and do this in person, actually. So it's good to meet you all. I'm going to whiz through the slides there. There's quite a few of them, but what I'll do is I'll run through them. If there's any questions, I think we'll just take them afterwards. If there's anything really specific or just a point of clarity, then obviously say so during it, and then I'll try my best to try and answer those questions. And then my colleague Kelly is joining us virtually, so she'll be chipping in at some point as well. I just need to let you know, it's quite poignant. She's had a tooth out, and that's why she's not here today. So she's struggling a bit, but she's joining us to help out. Okay. So what we've got here is a sort of just a bit of an overview, really, in terms of the contracted services in terms of dentistry within Ealing, and it just gives you a sense there in terms of the numbers of providers we've got, and just what the associated contract value. So you see, even for Ealing, there's about £20 million worth of general dentistry, NHS dentistry commissioned from within Ealing. Northwest London as a whole is the biggest patch that we have. I think it's just worth touching on the fact that obviously there is a lot of press around, there is a lot of scrutiny around dentistry nationally. And as we go through, I think it's worth pointing out that it's all relative to where you are, but the position in London compared to the rest of the country is quite different. So the position in London is far more favourable in terms of both access generally, but also just access to other dental services as well. Doesn't mean for 1 minute that I'm underestimating that in some cases it can be difficult for people to access services from time to time. But say relative to other parts of the country, we're relatively well served. Just move on to the next one there. So again, just to give you an overview, these slides are obviously in the pack, so you can obviously refer to those. But just to give you an overview, we commission on behalf of the ICBs now the whole pathway for dentistry. So obviously you've got your level 1, which is effectively your high street dentist. Level 2, which is sort of in between, so can be treatment that's delivered within a primary care setting, but would be, say, slightly more complex, but would have in the past been referred to hospital. So this would be things like minor oral surgery or even root canal treatment, endodontics, because they can be quite a gap between what's delivered at a primary care level, but also not complex enough for hospital. And actually patients can inevitably be ping pong between the two. So we have that level of service. And then level 3, if you ever hear it referred to as level 3, is hospital services. And I think the bit that sort of sits across all of this is the bit at the bottom there, which is the community dental services, which are a service that's targeted predominantly at paediatrics, but also for special care, both children and adults. And then they see obviously some of the more what you would term hard to reach groups, so things like the rough sleepers, and actually do domiciliary type care as well. So just to give you an idea of the spread of dentistry, it's not just centered around primary care, it goes right across the whole pathway. So again, there's a bit more detail there. It just gives you a detail. So you do have both an IMOS provider and an endodontic provider in Ealing. There's a bit of detail there, which I won't go into. You can pick that up in terms of the types of contracts that they exist under and how they're managed, really. In terms of CDS, really important. So across Northwest London, the provider is Whittington Health, but they also deliver across the whole of Northwest and the whole of North Central as well. They, as I said, they are your special needs provider, but also I have a targeted service for paediatrics, and I'll just touch on it. So the pathway that exists in London is unique to London in as much as referrals from GDPs, paediatric referrals, don't go straight to the hospital. They're into our CDS provider, who triage out the more complex stuff, which goes on to hospital. The CDS do an awful lot of paediatric dentistry. But the good thing about that is what that has is that's seen a reduction in the numbers of general anesthetics, because actually quite often children can be treated without that in the CDS because they don't have the pressure of having to do it within a very, very fast turnaround, which GDPs have to because they're working under a UDA system. So we have that in London, which is hugely beneficial because it has the number of children admitted for GAs reduced significantly. I think the one other thing to say about the CDS, which is really important, is the link across to local authorities in terms of oral health promotion. If anyone's not clear, oral health promotion is actually the responsibility of the local authority, but it's quite often delivered by the community dental service. So there is some clear partnership working, which has been in place for years. This is not something that's new. Please move on to the next one. And then just looking into secondary care across London, obviously we have contracts with 17 hospitals across London, but obviously there's a wide range of delivery, and obviously no specific acute provider in Ealing, but we obviously London Northwest, who we commission dental services from. But I think it's really important to know that services in Ealing or anywhere else, they're not limited to a borough or an ICB. The pathways that exist in London are across London. And I think it's a key part of the move to ICBs is actually, it's not an exact fit, because dental patients aren't registered with a dentist for a start. And patients, what you'll find, and there's plenty of data around now, the patients access dental services all over London. It's not confined to any one area. Some of it will be dependent on the specialty that's delivered by a specific hospital, but there may well be some reasons why a patient lives there but accesses services over here. And that integration actually works well for a population like London. And so I think one of the things is we're keen to sort of try and enhance that. But just to sort of make it clear, there's no barrier there. And we're sort of keen to maintain that. Just move on to I'll go on to that. That just gives you some details of the contract values in place. But again, that's something that you can refer to at another time if anyone's interested. I think just to touch on the pandemic, and we are, I think we've moved to, if I bring it right up to date now, primary care delivery is back past, in fact, is gone back to pre-pandemic levels of activity, I'm pleased to say. And again, that is a situation that is unique to London. Outside of London, contractors are struggling for various reasons, because obviously bigger geography, smaller populations make it harder, and there are less people delivering NHS dentistry outside of London. But we are back up, and the year-end position for primary care delivery across Northwest London is 95%, which is absolutely staggering, given where we were. There are a number of reasons for that, but a lot of that is down to the additional investment that's gone in, and the ICB put considerable amount of money extra in this year. Contractors have been allowed to overperform, which has meant the access has been maintained, and we're keen to make sure that that continues. So we don't want non-recurrent scenarios. We want something that's there in perpetuity. Obviously, I won't go into the impact of the pandemic, at least to say that obviously the bit that really is important is the urgent care delivery that we have in London. So urgent care was always there to a certain extent before the pandemic, but what we have now is a triage service that operates right across London 24/7. That was flipped over to a 24/7 delivery during the pandemic, because we are experiencing at its height over 2,000 calls a day from people who needed access to dentistry. And as you know, dentistry was shut, dental practices were shut. So we had to effectively establish urgent dental care services. It became very apparent to us that this was not something we could wind down. And we can't, and we haven't done. And in fact, we've just formally procured urgent dental care delivery for the next 5 years. Every borough has an urgent dental care provider. They operate at different times, but the triage service via 111, so it just goes into 111, and then it goes across to the triage service, is open 24 hours a day, which means, just for anyone's clarity, patients in pain in London do not need to suffer in pain, and there is a service that will help them. And this is predominantly either for patients who don't have a dentist, but also people who do, but just can't access it for whatever reason. And it's enhanced beyond where we were. So obviously not everyone wants to schlep across London at 11 o'clock at night with toothache, but they have the potential to then be seen the following day and that type of thing. So it's a comprehensive urgent care delivery. And again, not something that really exists outside of London. Yep. So again, just a bit of the recovery phase, which I won't go into. I've touched on it a little bit, but you can see that there in terms of some of the pilot programs that we're working on now. But as I say, urgent dental care continues to support general practice as well. This slide will be updated, because basically this obviously takes you back to contract delivery, back to the sort of 1920, which was obviously the first year of the pandemic. And obviously contractors were working at a reduced level of delivery, because obviously they weren't able to see the numbers of patients because of the social distancing required. But we've built back up. And as I said, this will be updated because we are now back up to pre-pandemic levels of activity. So just really, I think just in terms of the bit to touch on there really is the roadmap, which we established 3-4 years ago, which we continually update now, which was really our sort of go-to in terms of our recovery of dental services, and continually updating that. And obviously the move to ICBs has probably enhanced that a bit. And it's something that we're continually revisiting. So yeah, I won't ask you to read that, but it's there anyway. That is the roadmap. Yeah, so there's been some changes, some subtle changes, if you like, in terms of the contract that the dentists, the GDPs work under. They aren't the answer, if I'm honest. The contract really is overdue reform, has been overdue reform for years. But I think what we're doing in London is we're working with it as best we can and working around it to try and get the best we can from a patient point of view. And in some respects, whatever priorities there are for certain groups of patients, the biggest single common one will be access to general dentistry for people. So actually, in terms of one thing you can do is actually put that resource into dental practices. You get the activity and the access back. And we're seeing that borne out actually in terms of the data we've got now. So again, just some, I think some touches, this sort of cuts across really into the public health domain as well. But I think sort of one of the major impacts of or a number of the impacts of the pandemic were around higher rates of tooth decay within children, but just in general, because people didn't go to the dentist, couldn't, so maybe things that were fairly low level then became more serious because they weren't able to access it. Obviously, people's mental health took a major blow during the pandemic as well, and actually that can be exacerbated obviously by people with tooth decay. So when people ask why was the recovery slow, what's so slow, that was one of the main reasons. I think the analogy that a dentist said to me before the pandemic, a patient might have needed 1 filling. They've come in, they need 3 or 4 now, and inevitably that takes longer to treat. So there's less access available for people, and it's quite that simple. You throw in actually the workforce pressures as well. And it was a perfect storm, really. But they're coming out the end. They are coming out the other side of that now. And there you can just see sort of a ranking there. That was based on the 2019 the dental epidemiology report. So you can see where Ealing ranks in terms of experience of tooth decay for 5-year-olds. So sort of at the upper end of the chart. And then that was the most recent one in 2022. So you can actually see from a point of view of that it's actually deteriorated in terms of where they are. There's just some pilots there, which we've worked on. Some of this was work that started under the auspices of NHS England, and I've carried across a number of things. I think one to pick up on particularly was around looked after children. During the pandemic, obviously access to dentistry was very, very difficult. And actually we made provision for this by making it available to any local authority that had a looked after child to actually, we could get them seen, because obviously it's a statutory obligation to actually get them seen dentally. And we were able to actually get them referred straight into our dental access centres because they were available and open. But there's some detail there on some of the pilots, but I won't go into too much detail now. So that was it. So it's a fairly whistle-stop tour through where we are, and I'm happy to take any questions.
That's really helpful. Thanks. Anna, did you want to add anything from a public health perspective?
Thanks, Chair. I'll just do this verbally. So I think some slides have been shared, but just to say, I think like Jeremy pointed out, oral health promotion and the link with inequalities is actually a local authority responsibility, but we're very, very close working. Yeah. Like you said, that Whittington actually have the oral health promoter that we work in partnership with. Each borough does it differently. Yeah. And we are actually looking at our whole public health grant at the moment and seeing if it's an area we might want to prioritise a bit more over the coming years. We've done lots of things with non-recurrent money as it's come, which is great. So we've had one lot and just doing another one at the moment of oral health bus. So this is one with some fabulous dental trainees going out to schools, children's centres, community centres at the moment. And I think we're on to our 3rd out of 6 in our current series, but not just the dentist side, actually there with our Sugar Smart colleagues, really promoting healthy eating with families, school readiness. I really think linking in with health visiting and school nursing as well, and lots of other children's services, and also some of our cost of living services are there as well. So that's really good partnership work. We've got lots of work going on through the oral health promoter with schools, nurseries, children's centres, and we're also linked in. There's a programme across London called Healthy Schools London, which looks at a lot of things, but the kind of dental side of it is really really important. So yeah, it's really positive work, but it's something I want to kind of try and over the next couple of years pin down a little bit more.
Yeah.
Really try and have a bit more of that joint planning and really look at that investment. Thank you.
Brilliant. Questions from colleagues. Councillor Conti.
Thank you. A really interesting presentation. I guess one of the things I didn't really capture from the presentation or from the slide deck was overall in Ealing about where the gaps in the provision are in terms of where the dental practices are. Are there particular bits of the borough that, maybe don't have as many dentists or as many dental practices that are required? And I guess what's being done to try and address that. And then in terms of the urgent dental care, in terms of where people go in Ealing for that, is there a particular practice? What's the particular site for that as well?
So in terms of the where dental practices are, so that's a legacy. They are where they are. And we haven't specifically done any mapping to say, well, we need some here, here and here. That would generally be on the back of an oral health needs assessment, which would determine whether we've got a lack of coverage. I would suggest we probably haven't. And I think one of the things to bear in mind, obviously, as you know, there's no registration with general dental practice. There hasn't been since 2006. You might have an ongoing relationship with a practice, but you're not registered with them because it doesn't exist. It's nothing like a GP practice. So when you hear of a patient saying, "Oh, I've been thrown off a list," they don't exist. A patient a practice might say, "We're not seeing you anymore," and that's legitimate because their obligation extends to a course of treatment, and that's it. Many people don't know that, but that is the reality, and that's been like that, say, since the contract came in. As far as the urgent dental care is concerned, what will happen is if a patient rings up, there is a provider in Ealing, but it goes through 111, so and goes through our triage service, so they will be directed to whatever the nearest urgent dental care centre that's open at the time. Now, obviously, what they try and do is obviously get them a slot closest to where they live. So if the provider in Ealing is open at the time, that's where they'll be sent and they've got slots. But if they aren't, they'll be directed to the next nearest one, potentially. So it's not a direct, so GDPs don't refer directly into the urgent dental care. It's all through the triage service. So to give you a rule of thumb, we're still experiencing about 1,000 calls a day from patients. Roughly across London, we have about 500 appointments in a 24-hour period. So they are triaged out. Not everyone who rings up gets an appointment because not everyone needs one. And obviously they're offered pain relief advice and all the rest of it. But coming back to your point about dental practices, obviously that's one of those things that as we go through, now the budgets are effectively devolved down to the ICB. If the ICB deigns that actually we think we do need to procure some new dental practices, then that ability to do that exists to do that.
Yeah, Councillor Conti.
So I guess there's no mapping that's been done. I guess it's how do we know if, how do we know what the unmet demand or need is? That's why I don't understand. How do we quantify that? So there's no list. Is there any way of doing that sort of piece?
It would be, there would be some indicators from a public health point of view to indicate in terms of oral health decay and all the rest of it. But because effectively dental practices, my colleague Kelly's going to come in on this in a sec. But effectively, I suppose where dental practices are concerned, and this is really important now, the money that an ICB gets for a dental contract is by virtue of the fact that dental contract is in your area. It doesn't in any way pertain to patients from your area. Anyone from anywhere in England can be seen by that practice. They still get paid regardless. So in a way, anybody can access a dental practice anywhere. It's not about residents. And because there is no registration, that's a really key point. So when ICBs are now quite legitimately looking at population health, with dentistry, it doesn't quite fit because you will have patients inevitably seen from your area, but there will also be a large cohort that go to a practice that don't come from your borough. So, and I think it's a bit of a conundrum for ICBs, because saying, well, we want, you know, for our residents, understandably, but actually you can't restrict it. It's not restrictive. You can't restrict access to a practice to patients in an area. It's not like general practice where there's a catchment.
I'll bring Kelly in.
Thank you. Can you hear me? Okay.
Yeah,
Yeah.
that's fine. You're grand.
Fantastic. So just to say that in Ealing, Ealing is one of the boroughs out of all of the boroughs in London that has the largest number of practices. The spread of Ealing is probably better, definitely is better than anywhere else. I was previous commissioner, PCT World, of Ealing and Hounslow. And what I can tell you is that Ealing spread is pretty much that traveling wise, I don't think you've even got like literally a 1.5 mile gap, which is unheard of pretty much. So the coverage in Ealing and the spread is fantastic. That's naturally fallen, as Jeremy has said. It's not something that we've put there. We did some mapping in 2006 when the new contract came out, and we've probably got those maps somewhere. And I do remember looking at Ealing and talking to our public health colleagues at that point, saying the spread in Ealing is probably one of the best. So to give some assurance, there is a real good spread in Ealing and a huge number of practices. And the other thing just to say is the reason why we haven't gone out and public health info to see if there is the need for new practices is because you haven't actually lost any. So there's been no terminations in Ealing since 2006, which is when that new contract came out, apart from some very tiny one domiciliary equivalent contract and one contract which had, so again, units of dental activity wise, a really, really tiny contract. So you haven't had any large closures or anything. When that happens is when you normally turn around and go back to see where you'd want to put a new service. But as it stands, there hasn't been that. And the last thing just to mention is in 2006, when the new contract was being commissioned, one of the things we did in Ealing and Hounslow was we looked at things like training, etc., and what money was already in that contract. And we pulled some of those out and added more units of dental activity. So we were able to take out things like training elements, etc. And I know we did that in those two boroughs because I worked, you know, sort of beside the then commissioner. So activity wise, you've probably got more activity or more definitely more units of dental activity than what would have been commissioned in 2006. And then we've talked about capital money, etc. But there has been additional funds that have gone into dentistry in Ealing and Hounslow over the last sort of 16 years of the contract. So it's definitely been more input into it on a permanent basis. And sometimes there's been a lot of non-recurrent. But just to say the spread and the equal amount is good. And the last thing is you talked about how would you know if there was the need. Again, obviously we'll pick up things from patient complaints, etc., or you know what that spread looks like. And Ealing is not, I can assure you, not a problem area as far as access is concerned. There is fantastic access in Ealing. It's just capacity wise, as Jeremy has mentioned, you know, meeting targets. You'll have some that are underperforming, etc. And that's the bit we're working on.
Thanks very much, Kelly. Further questions? Councillor Steed, and then I'll go to Mr. Cook.
2 questions, if I may. One very quick one. The figures right at the very top of the agenda of 43 GGS providers. Is that individual dentists or is that practices?
Practices.
Okay.
Yeah.
So potentially there's
significantly more dentists than that. Yeah.
Okay, that's fine. Thank you. Can I go to possibly to slide 16? Is that possible? Where Ealing is there's the league table, if you like, of tooth decay amongst children. I think it's slide 16, or it was 16.
Yeah, there was 2 there, weren't there? There was
Yeah.
2019 and 2022.
That's one of them, yes.
Yeah, that's the most up-to-date one.
Okay, so I guess the obvious question is, whether it's Jeremy or I don't mind, don't care. We're not exactly not in the best position there, quite clearly. And I mean, I could understand, for example, why anecdotally higher income areas like Richmond might be doing very well. But there's places who are doing very well, like Lewisham and Southwark, who, with all due respect to Lewisham and Southwark, I would imagine that I don't know how different they are demographically to Ealing, for example. And whether that partly explains because of the ethnic mix of Ealing, whether that partly explains the figures or not.
Yeah, I mean, I don't, there's no correlation between that and actually the number of dental practices we've got. I think obviously the wider determinants of health and other aspects will impact in terms of people's decay, because obviously, like we said, the dental access is there, and obviously we've got pretty comprehensive services. So I think there are probably other factors around that in terms of whether it's, you know, economic, social deprivation and that type of thing.
Anna, do you want to come in terms of kind of public health interventions and some of the detail around it?
Yeah, can do. So, so two things I would point out just on the data, with the big lines that are little black lines are showing kind of how confident we are in those figures. I wouldn't pull out specific boroughs to look at because a lot of them overlap. So yes, but we are at the higher end and we have been for quite a long time. So it also goes hand in hand with child obesity, which we're quite high on. A lot of links with deprivation. When we have done things like the outreach events, the oral health and things like that, we are coming across lots and lots of families, especially recent migrant families, families that aren't speaking very little English, don't understand the local systems. So apart from the kind of oral health promotion side that we're doing through schools and with individuals, we're also trying to I'm going to use the phrase sign up, apologies, sign up and refer families to local dentists and actually following them up a week later to check that that's happened and if they need help with that and everything else. So there's lots and lots of different activities there, but it is high on our agenda. We have got a bit more detail about child health. That's maybe, I think, 2 years ago, and we're looking at refreshing that, I think, next year. That's in our joint strategic needs assessment. So that might be something I can send the link to Anna Marie that's got a little bit more details on this, if that's helpful.
Yeah, that'd be great. Thanks. Dr. Taylor, is it on that point? Yeah, excellent.
It's just, again, regarding sort of oral health promotion in children, we have done some training, particularly in relation to general practice nurses, because clearly the first opportunity in terms of children having their first dental check is at the age of 1. And so, when they come in for their 12-month immunizations, that has been a great opportunity in terms of encouraging parents to ensure that they get their child seen for the first time in terms of their dental checkup. So we did do some training with practice nurses in terms of how to approach that subject with the parents, and having a greater understanding and some level of empowerment to how important that first check is, at the age of 12 months. So, but nevertheless, as you see from the dental decay, it is not good for Ealing. Not only the dental decay, but also in terms of the number of hospital admissions related to children for dental decay. Ealing is one of the highest in London, and so it is multifactorial. There are lots of wide determinants as to why this is happening, and we have been trying in Ealing, particularly in terms of our Children and Young People's Board, in terms of trying to look at how we can try and address that. We do have a subgroup looking at oral health, but there's still a lot that we need to do.
That's really helpful. Thanks. Mr. Cook.
Thank you, Chair. You've talked about emergency services and contacting 111.
Mm-hmm.
How do you inform the public that this is the way they should actually deal with the situation? Because, okay, if you phone up your GP, there's a message. What happens? How do you get that information across from a dental point of view?
So there's a number of mediums. I mean, in respect of, so if I use one example, so if anyone pitches up at A&E with a toothache, they are pointed to that board, the posters, they've got them. Obviously, we've always gone out and reiterated the messages to the wider stakeholders, because obviously previous to this, we're at NHS England, so we'd have circulated that information to what was then the CCGs to make sure people are aware. But it's one of those things, information doesn't always get passed on. So what I want, and we've done this with all of the, I think I've done more health and scrutiny committees in the last 6 months than I did in a lifetime at NHS England. So one of the things is to actually, if we can get the message out via organisations like a local authority as well, because it's, for us, it's key, because that service is there, it is being accessed, as I said, up to up to 1,000 calls a day would suggest that people do know. And obviously, if people just go through to 111 inadvertently, they might go through because they don't know where else to turn. That's where they'll be directed through. So you are, to a degree, reliant on word of mouth to a certain extent. And I think a lot of people find out about it that way, because obviously there are still lots of people who don't have a dentist. And that'll be for a number of reasons. Maybe they're finding it hard to get one, or a lot of people just don't want one. Because obviously there is a financial aspect to that, and urgent care as one tariff. But I think, in answer to the question, it's just the usual modes of getting that information out there. And obviously it's not something that would be advertised sort of in a national way, because effectively this service that's operating is unique to London. So if you're in, and how it works, just to give you a sense of this, if you happen to be in London and make that phone call, you may not be from London, but if you ring from within the London boundary, you will be triaged by that service. If you ring from outside of London, the service is not available to you. So I think it's, but again, we're happy to make that information available to anybody who wants it, so that people in London know that they can access these services, because it's there for them.
That'd be really helpful if you are
Yeah,
happy
sure.
to share that. Any follow-up, Mr. No, thanks. Yes, if you'd like to come in.
To that, one of the ways that dental practices are aware about this urgent care service, and so when patients call us and if we can't see them with toothache, then we will point them to NHS 111.
That's really helpful. Thanks for that confirmation. I just had a question myself in terms of the dental contract. I think you mentioned that it was overdue changes. I'm just interested to know from your perspective what you would be hoping for from those changes.
Well, apart from starting again, I think, I've got a GDP that sat next to me here. I think we're all at one here, commissioners and providers. Like any contract, this has been in place since 2006. It may have been deemed to be the right thing at that time, but it's long overdue reform, and the rigidity of it, in a way, is actually detrimental to patients, because the way it's funded means that actually it's not, in some respects, viable to offer many of the treatments on the NHS on there. So in a way, you almost stealth moving towards a core delivery of services, and then everything else falls outside of that. So, to me, it can either go two ways. You can either have a formal, refined core delivery, or significantly more money is put into it. And then it just makes it something that actually is more attractive for providers to deliver. Because at the end of the day, dentists are businesses like everyone else, and that we contract with in that respect. And they can't be in a situation where they're delivering stuff that's actually losing the money. And in some cases, some treatments do, because of the costs associated with either the materials they use, and just the actual cost of, labour.
Thanks very much for that. I'm not seeing any other indications. Oh, Neha, sorry.
Sorry, at the last scrutiny meeting, a series of questions was raised, and I just wanted to close the loop in providing the answers to those 6 questions as we've drafted. And we've already answered some of them, but I'll just recap what those were, if that's okay.
That'd be lovely.
So the first one was, how is information being shared with residents on which dental practices are accepting new patients? And the answer is residents can search for a dentist using the NHS website, which has a find a dentist component to it. And the nearest dentist will then be listed, and they'll confirm if they are accepting new patients. There is an acknowledgement that this is quite variable and not always up to date, but the dental practices are required contractually to keep it updated as much as possible, but it can change very quickly due to demand and capacity. Second one is, how are dental contract locations impacting residents? Are we ensuring that we have dental contracts in the most economically deprived areas of the borough? I think Kelly has already answered that one. That was the same question as what Councillor Conti had asked. How are dentists ensuring that residents know about available payment plans, so that they are not reluctant to receive care due to financial impact? NHS dental providers are required to display the most up-to-date NHS dental charges in their waiting rooms. Payment plans are not part of the NHS dental charges fee structure. How is knowledge being shared in schools with young people about the importance of taking care of their teeth? Are schools being visited with dental supplies, sample packs, and information booklets? This information is provided by Whittington Health CDS. Ealing Smiles Daily. Supervised toothbrushing for 3 to 5 year olds in targeted schools is provided as well. And oral health training and resource packs developed for workforce in childhood settings for 0 to 5 year olds, alongside the provision of toothbrushes and toothpaste to targeted schools. What is the specialist dental service offers for people with learning disabilities, and what is the current waiting time? It's understood to be 12 months. So Whittington CDS provide this service, assuming we're talking about children here. Special education schools receive dental screening for SCN children, occupational health training for staff, occupational health training for SEN parents as well. And then the final one was, what is the current access to dental service of people in care homes? There are currently no specific services for care homes, partly because there's very little that can be done whilst the individual is within a domiciliary care setting. It's limited to work like denture care. So always try to get the individual into a clinic settings, and that's a discussion with that local dentist close to them.
Thanks so much, Neha. That's good, and really good of you to close the loop. Our Health Watch representative isn't here this evening, but I did, in advance of this panel, request a briefing on some of the issues from patient feedback into Health Watch. So as soon as that becomes available, I will circulate that to the panel, because there may be further questions that kind of stem from that. But thank you very much, Jeremy, and all of your colleagues for your presentation. Really appreciate it, and we seem to have stuck to time as well, which is a miracle. So thank you. So we will move on now to our item on sexual and reproductive health. Thank you very much to all of the colleagues that are joining us for this item, and special thanks to colleagues at Mattock Lane for facilitating the scrutiny panel visit recently. It was a brilliant occasion to learn more about the work that you do. Anna Bryden, our Director of Public Health, is going to say a few words, and then I think pass over to Jane Darroch, who's one of our public health principals, and you're going to provide the panel with a presentation in relation to kind of the key sexual and reproductive health needs locally, and then there'll be an opportunity for questions. So I will hand over to Anna in the first instance, and I know other colleagues will help with responding to questions, so that'll be great. Anna, over to you.
Thank you, Chair, and thanks for the invite to have this item here. I think we've obviously had the Joint Strategic Needs Assessment relatively recently and brought that to Health and Wellbeing Board, but I don't think we've had an item on sexual health here for a little while. And I think it's great that you managed to go out to the clinic with panel members. And I think when we were talking about this, we thought it was really good for the service to be showing their work on inequalities particularly. And I think some of those real life case studies are in here, because I think, we talk about this quite theoretically with the health and wellbeing strategy, but a lot of our services, especially sexual health, is really kind of shining light on that. So massive thank you to all for coming today, and I'll hand over to Jane.
Thank you. Anna Marie helped me at the beginning with my PowerPoint, but I can't find it. Sorry. But I can just talk through it if that's easier. Yeah, we did quite a very comprehensive joint strategic needs assessment in 2022. And we've updated that in the report on key indicators. But as Anna said, we've also included some case studies of real lived experiences from our residents on sexual and reproductive health issues that just kind of illustrate the complexity of some people's lives and multiple needs. So I think we're still struggling with the power. Oh, Anna Marie's going to do it. Okay, so just, I suppose the perspective we want to take is that obviously sexual health and reproductive health is universal. Anyone who's sexually active is, potentially at risk of poor sexual health. However, just to kind of frame it in a positive way, that as with the definition of health in general, sexual health is not only about the disease. It's a state of physical, emotional, mental, and social well-being in relation to sexuality. So this is important because the issues that impact on good sexual health include information and knowledge, up-to-date information and knowledge that's accurate, and also about people's beliefs and understanding of their own risk, but also, as well as that, access to sexual health services, not only in specialist sexual health and reproductive clinics, but also in the settings that people access every day. And also, what is really important is a positive attitude towards sexual health, because things such as stigma or embarrassment can lead to poor sexual health in terms of accessing services, but also in terms of healthy relationships and speaking about sexual health issues. Although the universal issues, there are well-established health inequalities with sexual health, and there are known groups that have higher risk. These include gay, bisexual, and other men who have sex with men, but also within an inequality is also amongst gay and bisexual men who are HIV positive, who are more likely to have a bacterial sexually transmitted infection. Young people under the age of 25 are a high-risk group, and also BME communities have a higher risk of bacterial STIs, but also some BME groups also have higher risk of HIV. So in terms of need, within the report, there's quite a comprehensive updated list of the indicators of sexual health. Just to highlight a few key issues which we've discussed throughout this process is the increase of sexually transmitted infections, which reduced during the pandemic, but since pandemic, they have gone up to pre-pandemic levels. Other things to highlight is also that the whole of London is considered an high HIV prevalence area, and late diagnosis of HIV is also something that we, are collectively working together to try to reduce, because obviously the quicker that people get to treatment and care, the better outcomes for them. And also for Ealing, unfortunately, we also have a high abortion rate, which is preventable through obviously access to contraception and knowledge. And kind of linked to that is a contraception called long-acting reversible contraception, which is available in specialist contraception clinics, but also in general practice. And within our special clinics in Ealing, we're very high. There's very high performance on that. But within general practice, the performance is really quite low, which kind of reflects, obviously, the pressures of general practice. So just to highlight the kinds of services that provide sexual health, are not limited to specialist clinics, but they, as with dentistry, Sexual health clinics are open access and residents can go outside the borough and residents from outside can come to Ealing. Other places obviously are general practice pharmacies, outreach and prevention, particularly amongst for those high risk groups. Schools, sex and relationship education is now a statutory requirement in schools. Abortion services, we've been working with the ICB on procurement of abortion services to integrate contraception and STI testing into those services. Midwives and other hospital settings such as HIV testing in A&E. And also to say about the London Collaborative, that's where London councils work together on the commissioning of clinical services, but also the online testing and treatment service with some contraception called SHL. And that is fully integrated with the clinical services, but also across London, the London HIV prevention programme, which is about awareness about HIV and other STIs. And also we obviously support national campaigns as well. And HIV clinics for people living with HIV and HIV support services. So just to highlight where the clinics are in Ealing, this map shows the darker areas show the higher prevalence of STIs. So the clinics are based in central Ealing at Mattock Lane and also at Central Middlesex Hospital. So it kind of shows with the darker areas that they are located in the right parts of the borough. When we inherited the service, the services were based Ealing Hospital. So it is, you know, more centrally located. And finally, this just sort of illustrates the complexity of the sexual health commissioning landscape, as well as lots of providers. There's also different commissioning responsibilities. So an example would be local authorities have a mandated responsibility for STI testing, NHS England for HIV treatment, and ICBs for abortion services and gynecology. So it is really important that we all work together because sometimes there can be gaps. So it's really important that we all work together. So finally, just some data sources for further information. And as I said, we have colleagues here who would like to say a few words about their own services.
Brilliant. Who are we going first to? Shall we start with Dr. Hampton?
Okay. I run the contraceptive and sexual health service out of Mattock Lane for the borough. We also have one clinic a week in Southall Broadway Health Centre, which is specifically staffed by a receptionist, doctor and nurse, all who speak Hindi and Punjabi. We would like to extend that a little further, but we're slightly struggling in terms of staffing for that. We provide a comprehensive service out of Mattock Lane. All methods of contraception that are reversible are provided. And as Jane said, we actually have very high levels of LARC provision. But in addition to that, we also do a lot of pills, patches, rings, injections, so that women do have a wide choice of methods. We don't only provide long-acting reversible contraception. We are an exclusively female team, which is culturally quite acceptable to our local population. And I think in the pack you'll have a slide that shows actually the breakdown of the local population and the breakdown of the population that we see in clinic, and they really are very, very similar. We have a lot of staff who speak appropriate other languages, and we do a lot of consultations, not in English. And I have one poor doctor who I don't think ever does a consultation in English because she speaks Arabic, Polish, and French. So she doesn't do very much in English. So we try to, wherever, obviously we use interpreting services, but we try wherever possible to use staff who are culturally aware of issues and who can do the consultation directly in different languages. We're very active on with teaching. We train, we have GP trainees from the local VTS scheme, and we now have an ITP post whereby we get somebody every 6 months for 3 sessions a week. We take other GP trainees. We also offer training to established GPs, and I'm pleased to say that from the 1st of August, we will have our very first consultant in sexual and reproductive health training post in collaboration with Imperial. So I'm just in the process of writing her 6-year training plan at the moment. I think I've got to about year 3 so far. So we do a lot of training. We are a small number of people in terms of whole-time equivalents, and we are a very mature staffing profile, she says politely. Nobody goes on maternity leave. They have their cataracts done in my service, which is the truth. And I'm saying that to highlight the fact that actually there is a real issue with knowledge and skills in particularly anybody below the age of 50, 55. And it is actually quite a problem going forward in order to attract people into the specialty so that we can continue to provide services. Is there anything else you would like me to say?
I think that's great. I think we've heard the message loud and clear that you won't be able to retire anytime soon.
There's a consultant in Southwest London who's 80, so I don't think I'm going anywhere quite yet. But
thank you very much. Dr. McSorley, shall I pass over to you for a few words as well?
How to give an overview? I think it's the best of times and the worst of times, particularly in sexually transmitted infections. Jane's alluded to, we're dealing with the highest numbers of gonorrhea cases on record. Records began in 1917. And the highest number of syphilis cases since the Second World War, which was an unusual peak. I say it's the best of times because actually we have an enormous plethora of combination interventions, things that could work. We also have to register our London privilege. So London is both the European epicenter of sexually transmitted infections, but we're a real center of innovation, and no other city has anything like the local authority created collaboration Sexual Health London, which makes STI testing and emergency and oral contraception methods available to the residents of participating boroughs. Actually, there's one other capital. Dublin now has commissioned something similar for the whole country, but they're dealing with a population of 5.5 million, whereas here we're working collaboratively to cover 10 million, plus or minus those who come into the city. Those who come into the city, London is a sex-positive city. The people come here for sex. We also know this in our own borough. We have many 10-story buildings where there will be commercial transactions take place in each and every one of them. So it's important for us to be out engaging with our population and being conscious of what happens, because pretty much sex is part of everybody's life. So we are very sex positive, but we have many challenges to meet. We also understand totally the value of relationships. And actually, I think our professional relationships, we are able to mobilize every resource that is available to us. For example, our working with our 2 specialist services, or specialist hospitals rather, at Ealing and at Northwick Park. So these are recognized centres where the expertise of our infectious diseases colleagues in managing conditions and providing acute care to people living with HIV, but also ongoing long-term care. It's our metrics in terms of the clinical outcomes for the populations that we serve are on a par with all of London, and London services are head and shoulders above most other services. So there are a lot of positive things, but actually sort of many acute challenges that we have to face. And currently we're facing something of an upsurge in STIs. So I think that both calls for additional and extended resources and interventions. But there are tools in our armamentarium that we need to deliver, make more accessible, reach out into populations in order to help prevention. I'll stop there, but I'll open to any further questions.
I was just wondering if you wanted to say anything more about you touched on the innovation and expertise, but particularly in terms of the role that clinicians at Mattock Lane had in terms of monkeypox. I think that was an area that was particularly interesting from the presentation.
Absolutely. So here's an example. So on the one hand, we're working in contracts where we now deliver against workloads that weren't even envisaged. So this is a novel disease. It appeared in West London. In fact, just a couple of miles from here is where the first case was, and recognized very quickly. But London was in the epicenter of what then became an international outbreak. This is a orthopox virus, very closely related to smallpox, which has amazingly been totally eradicated back in 1975. And the vaccine still works to this closely related virus. But its sexual health services, as they were attempting to recover from the predations of COVID, were immediately overwhelmed. And I say overwhelmed because it just flattened services. We had enormous difficulties attempting to deal with it. During the summer of 2022, but our local services actually sort of were among the first in the country to start vaccinating. And we continue to vaccinate at a higher rate than most of the other boroughs in London. Currently, the susceptible population is men who've sex with men. And this is a sort of a novel manifestation of this virus in that it's got into a population group and spread worldwide. We're working against this population, but also we're monitoring that currently this virus, other clades of it are beginning to exhibit the same behaviors in heterosexual populations in West Africa. So it is very closely being monitored both by our infectious diseases colleagues for new entries into the country, but we're still continuing to see sustained transmission in London. So that's going to continue to happen.
Thank you very much. Simon, I wanted to also just invite you to say a few words about the work that the excellent work that you do, and I think you have an exciting relaunch of your services coming up as well.
Yes, we do have a relaunch of our services on the 14th of June. It's going to be at Quester's Theatre, 2 till 4. So if anyone would like to come along to that, I'll also provide extra information. Jamie, let people know if you want to come to that. So Living Well works in close collaboration and partnership with Positive UK and also with NHS colleagues in Ealing to provide a range of health and wellbeing and peer support services, face-to-face, online and telephone, ranging from services such as counselling, life coaching, wellbeing workshops, peer support, welfare and benefit support. We operate from a main hub within Level 8 at Ealing Hospital, and provide services there face-to-face. And we also provide services across the borough in a range of different community-based venues, depending on sort of need and request. Most of the services that we offer sort of help people living with HIV deal with some of the main challenges they face, including mental health, stigma, both sort of social and self-stigma, loneliness and isolation, welfare and benefits, and also dealing and sort of supporting with areas around loss to follow-up or disengagement from services. So really helping people to re-engage or stay engaged with services. And as part of what we do as well, we also look to work in close collaboration with service users and use co-production, and also have set aside a small percentage of the funding that we receive to create an innovation fund, which allows us to look at unmet need and work with service users, professionals, in the borough to sort of identify potential areas and then to pilot services that the service users themselves get to vote on and decide upon and then report back.
That's brilliant. Thanks. And I'm sure that colleagues have noted the 14th of June for the relaunch. Beatrice, shall I come to you just to briefly explain about Positively UK as well?
Thank you. So Positively UK is a national charity working with people living with HIV, and ethos of our services is the peer-led. So myself, I'm a woman living with HIV for over 29 years now, and I manage some of our services, and I also work closely with Living Well with Simon. And as you heard, John alluded that everybody, does sex, but within that is also carries stigma. So people, especially the self-stigma, when people are diagnosed with the HIV, the sudden shock of, wow, how do I live with this? Even just like, who do I tell this news? Who do I share this? So by, accessing peer-led services, they are able to connect with people who are themselves, who have gone through where they are. And, myself, I had the same fears, like, who do I tell? How do I tell? How will I be received in my community? Which for some communities, it can be a challenge. So once they have access to peer support, it enables them to actually adjust and realize actually you can live well with HIV, especially if you have all these, Simon said, mental health, stigma. If you have all these addressed, you can live well. So Positively UK has been providing services in collaboration with all the other organizations, Living Well, Body and Soul, so many other organizations in the community. The reason being that there is always gaps. If sometimes you meet this need, there arises something else, and the ability to signpost people to appropriate services is actually very enriching in enabling people to live well. So yeah, thank you. I'm really happy to be here today and working alongside Jane and Simon.
And we're really happy to have you as well. So thanks so much, Beatrice. Now, I haven't forgotten about you, Simon, but we're saving you in reserve for dealing with any tricky questions that come up, if that's okay. So I will open it to panel members for any questions. Councillor Conti.
Thank you. I had a couple of questions. One was regarding the map with the new STI diagnosis across the borough in the different wards. And there was quite a big difference in different parts of the borough. And I was just wondering whether that's a reflection on people accessing sexual health service and therefore underdiagnosis in certain parts of the borough, or is that because of different behavioural, sort of activity that people are doing in different parts of the borough, depending on cultural lines, etc. So I just wanted your thoughts on that. The other thing was on PrEP. So there's some tables in the slide pack about it, and sort of the interesting one I thought was about how many when it's offered and how many different in terms of ethnic groups who reject it, etc. And I think when we were looking at the first slide, we were talking about so BME groups having a higher rate of infection, but there's some of the lower uptake groups in the chart. Sort of, I guess why is that the case? Because obviously they're presenting sexual health services, so there's a level of openness, in them coming forward in terms of not then wanting to take it on, and what work can be done to try, I guess, from a public health point of view, to try and help close that gap. And then the final point on that, I think isn't there a national pledge to eradicate sort of new transmissions of HIV by 2030? Yes. I guess, where are we on that journey?
Yeah, so a host of questions. So I think the STI maps are really detailed, and actually they're magnificent, I think, the way in which the UK HSA produced those for us. We know that there's very clear correlations between STI rates and social deprivation. So sometimes you're looking at something that looks like the social deprivation deciles. There's also clear correlations between population groups and incidence of STIs. So you may see the area of Southall where we know that there are lower rates of STIs amongst South Asian populations, whereas actually Naomi's map would be the other way round, which is that there's higher need for contraception services in those areas. So there's a little bit of divergence depending on the populations that you look at. You'll also see things stretching out along the access routes. So you can see the trail of going out along the Uxbridge Road but the most predominant phenomenon in London is that the closer you come to the centre, the denser the population, the denser the sexual mixing and or capacity stuff. If you went back 10 years and looked at the same map, the North Acton area, that East Acton stroke Hanger Lane areas, as population growth and a lot of building is taking place there, we're seeing sort of higher rates of STIs in that area, and also the area around South Acton where there's been a lot of development. So if you build lots of 1 and 2 bedroom flats and you bring in young populations, you will see rises in STIs there, because that's what people come to London for. So with regards to the perhaps the access to the services per se, I think that Sexual Health London, the online service, has flattened a lot of access, because actually everybody can access that if they've got a phone in their pocket, and it will send them back out to them. So I think that has dealt with a lot of the difficulties we would have had 10 years ago, where actually physically getting to a face-to-face service concentrated STIs because people turned up and gave the address of the clinic rather than their actual address. And now much of that is spreading back out again. Then going back to perhaps interventions such as PrEP, we're both on schedule in terms of what we had anticipated 5 years ago about PrEP delivery, in that there was a collapse during COVID, and then a sort of an attempt to supercharge that during 21-22. So we're seeing uptake rates consistent with what we might have hoped for 5 years ago, but actually we're simultaneously recognizing that we're not even getting there. There's been an unexpected hiccup in the ability to stay on trajectory to achieve eradication by 2030. Eradication gets more and more difficult the closer you get to the objective, because it gets extremely challenging to do the final case finding and get everybody in need, their needs met. So we should have been, we would have hoped to be able to stay on trajectory by reducing the transmission rates by 85% by, or rather new diagnoses by 85% by the end of 2025. In fact, post 2022, there has actually been a rise in new diagnoses. In this area, we are going in a different direction, but what we think is actually happening there, where we look at the demographics of people who are being diagnosed, is much of that is new immigration in the last 18 to 20 months. So we are picking up many more cases in the opt-out programs in accident and emergency at both Ealing and Norfolk Park, who are very high performers nationally. But most of those new cases are individuals who weren't in the country 2 years ago. And I think that tells about sort of there are competing dynamics that go on. If we were dealing with a frozen population, we are making progress. It's just the background constantly changes around you. But I think that tells us that we need to do an awful lot more work in all of the boroughs across London for reaching out and connecting very rapidly to our new migrants and our new residents. And I think that's a sort of a global responsibility. And then the latter comment about noticing differential uptake rates amongst the minority populations. We recognize that Ealing, like Brent and our other areas, we're actually hyper diverse. We almost have no minority or majority. We have varying. So our uptake rates are probably twice as good as comparable clinics elsewhere. So we do particularly good at achieving higher uptake in Black or Asian or other minoritized populations, but actually there's a significant deficit to make up. And much of that can be about hesitancy and uncertainty and I think you see this mirrored and mimicked in vaccine uptake. So the same populations who may be hesitant about vaccines. Coterminous with our PrEP work, we're also in those populations doing vaccine work for it, because the same groups would be eligible for hepatitis A, Hep B, HPV, and Mpox vaccine, and actually we see very, very high rates of vaccine uptake in those populations. So usually PrEP comes 3 or 4 times after 3 or 4 visits. It's just a bit too much for people at the beginning. But that's a challenge for us because in the last week, I have seen someone who presented to a service 3 months ago and was diagnosed with infectious syphilis, was offered PrEP, declined it because there was too much going on. And then they appeared in one of our services this week. And while we offered and they agreed to take PrEP on the day that they came in, we had to contact them the following day to indicate that they had already acquired HIV. So there's an opportunity missed. It's that paradox that actually prevention is emergency work. Because if you don't get people at the first opportunity, sometimes actually that's the opportunity to get the prevention in. So we simultaneously recognize the urgency of the prevention stuff that we do because it's super valuable.
That's right. Thanks very much. Any follow-ups? Any further questions from panel members? I have a question from Alex Cowan, who is a recipient of direct payments and involved in the Ealing Reclaim Social Care Action Group. She has asked how many sexual health clinics in Ealing have portable hoists and examination tables that go up and down electronically. Who's best placed? Dr. Hampton.
So all our clinic couches go up, down, head up, feet down, feet up, and go down virtually to the floor. So there is no issue with any of the couches. We don't have hoists, portable hoists on the sites in the community due to constraints of space, but also the number of staff needed to safely use hoists. Anybody needing examination and a hoist to get them onto a couch are either referred into our gynae colleagues at Ealing or Northwick Park, or into the HIV sites at Ealing and Northwick Park, where they could have their tests.
That's really helpful, thanks. And I'm sure Alex will have caught that on the live stream. And if there's any follow-up, we will take that forward. Any further questions from panel members? Mr. Brooks.
Just got a quick question. It's about people in Ealing living with HIV. I think I read in one of the reports somewhere that there's 2 different models. Sometimes they come under sexual health clinics, sometimes they come under NHS organs. What happens in Ealing?
I think what it was referring to was HIV support services, not HIV clinical services. As I showed with the diagram, different commissioning organisations have different commissioning responsibilities. However, HIV support is one of those that it could, in some areas such as Brent, the NHS commission HIV support, whereas in Ealing, it's a local authority that commissioned that service. So I hope that explains that. Thank you.
Thanks very much. Well, thank you very much, everyone. That was an excellent session. Really grateful for all of the work that you do. In advance of my visit to Mattock Lane, I did the Sexual Health London online testing. I would very much encourage everyone across Ealing to do it. It's so simple and straightforward. And I was, of course, involved in setting that up. So we've got a real star team locally. Thanks ever so much for your time, and we're really grateful to you. So we will move on. You're welcome to stay, but equally, I'm sure you've got homes and families to be with. So appreciate your time this evening. So the next item of business is the review of cancer screening program and diagnosis in Ealing. Anna is going to talk to this, and we're really pleased to be joined by Raj as well, who's one of our public health specialists. We only have a short amount of time on the agenda for this item this evening and for the immunisation uptake and delivery item. Really, they're coming to the panel for the first time in a very long time, and the idea is that we kind of flag up any questions or areas of further exploration so that we can think through what we bring in future meetings. So, Anna, I'll stop babbling and I'll pass over to you.
Thank you, Chair. So we definitely haven't brought these here since I've been in Ealing, and obviously had the joys of COVID for a couple of years in that. But as we've been going through all of our different public health functions and resetting our work in terms of where we're at with strategies and partnerships, it's something that for me is done very commonly across the country, is to essentially use the powers of health scrutiny panels in terms of immunisations and screening. So Raj will take us through in a minute in terms of they're both very almost like the little Venn diagram that Jane just showed us is even more complex for these two areas. But the council and the public health function has a duty of essentially assurance that the NHS services and other partners are working well, the needs of our communities in Ealing are being met, and the local authority role partly is the assurance function, but there's also an awful lot we're trying to grow the kind of community engagement side of that. So really look at the inequalities, work with our local communities, and support our NHS colleagues so that their work is really having the best impact in the local organisation. So we wanted to bring these two items here today as a bit of a starter, that thinking about the panel, where do you want to take this? Is it a case of potentially that we do a annual item, possibly one on the next year on screening? Raj is going to talk us through kind of some of the key needs, some of the key partnership work, both in terms of successes and challenges, and really good for the panel just to ask any questions and really maybe have a think about that forward plan for the panel items. Obviously, we would be inviting external colleagues to come and talk to the panel. So that would be really good for us to plan that ahead and really think about the key focus areas. Do you want me to have a go at sharing, Raj?
It's allowing me to share, but it doesn't allow me to do it as a slide show.
Okay.
So,
Well, I tell you what, we'll give it a go without the slideshow, shall we? And see. Yeah, that's fine. Yeah, don't worry, I'm sure. And we've got the slides, haven't we? So.
Right, thank you.
Brilliant.
Good evening, everyone, and thank you for bringing this item to the agenda. And I think it's really pertinent and important right now for us, particularly when we look at the local information for Ealing. And I was asked to just summarise, because there was a whole raft of data that was produced alongside this pack in the first instance and in the second instance, but we've tried to summarise it so that, you know, there can be thought around what do we do next. So I think particularly with the cancer screening, that's the one we're starting off with, all 3 screening programs, you know, the uptake around those has reduced since 2015 across Ealing. That is in line with what we see locally and nationally as well. I think the most significant drop for Ealing has been around breast cancer screening uptake. And if we look at the kind of the national uptake is 70%. And in our most recent figure, we were 47%. And that is, you know, very significantly lower than what the national uptake should be, or across national uptake. And that information we've further divided into our PCNs, and all our PCNs are also below the target for cancer screening. And when we look at cancer diagnosis, what we found is that actually when we look at diagnosis, we look at colorectal cancer, for example, we have high rates of diagnosis in Northfield, Greenford, Broadway, and these, if I go to the next slide, will show actually correlate with our areas of deprivation as well. So I think we do need to do more work into sort of understanding actually what is going on around cancer screening and cancer diagnosis locally. And I did a bit more work around the inequality, and we could really try to correlate it with our local PCNs as well and where the uptake was. And again, like I said, that I won't go too much detail into it word for word. I'll leave that for you to read. But there is a clear correlation between deprivation and screening uptake and diagnosis for cancer. And we often focus on only deprivation, and even if we look at ethnic minority populations, there's not the local data that's done for Ealing, but nationally there is a correlation of low uptake between ethnic minority populations and cancer screening and diagnosis. And we also find a similar pattern for people with learning disabilities as well. So although that's not included in this, that's also another area where we want to think about, especially if we're thinking about people's protected characteristics. And in terms of our kind of local actions, or just thoughts for people across the panel as well, is that actually NHS England are the responsible commissioner for cancer screening services, and they probably need to take more of a step in terms of giving more of an understanding around what services are available locally and what is going on. From the intelligence that I have, limited maybe, but it's very complicated. It feels really complicated right now when I've tried to and we're having our first cancer screening group next week. So hopefully that will start the ball rolling around thinking about this more as a system. And we do need to do more around a deep dive into cancer screening with all our services and our commissioners and the borough-based partnership and everyone sort of involved into that. And I think the other part of it that's missing is that kind of hospital late diagnosis. We don't have that information. I think it would be really good to get that rich data that would allow us, and also understand a little bit about the community perspective as well. So why are people not going for their cancer screening? What's going on? So that kind of community perspective and thinking about co-producing our local resources and materials. I'm going to stop there because I think I had 3 minutes and hopefully I've done 3 minutes.
Anna, did you just want to add something? That's
Yeah,
great.
thank
Thanks,
you.
Raj.
No, just wanted to add one point as well that links to screening and immunisations as well, is there's in the last kind of 6-12 months, we're starting to see national information about the HPV vaccine and its impacts, because that obviously started, I don't know how long, 15 years ago now, something like that, in terms of teenage vaccinations, and was then extended to both boys and girls. That's actually starting to now show impacts in terms of cervical cancer diagnoses, which is fantastic. That was always the plan, but it's really showing really high levels. So it's a really good success. But again, there's lots of there's relatively low rates of HPV uptake in Ealing, along with a lot of other London boroughs, and inequalities within that. So it's just something for us to bear in mind. It goes between the two a little bit, but especially with the immunisations. Thank you.
Thanks. Dr. Taylor, I can see you're indicating.
Yeah, thanks. Yeah, just a couple of points to make. One particularly around the bowel screen, and in fact, bowel screening uptake in Ealing has in fact improved since 2015, and that's partly due to we have been doing some work in Ealing around bowel screening, particularly in terms of those non-responders, and we have put schemes in place in general practice where GP practice get notification of those non-responders. We've actually proactively reached out to them, and in association with RM partners, Royal Marsden partners, we use community links to support us in terms of encouraging those individuals who have been non-responders to then, the importance of bowel screening and in terms of doing the postal kit. The other thing I just want to point out is that breast screening is very different to both bowel and cervical screening. One, during the COVID pandemic, breast screening was completely suspended due to the pandemic and to avoid virus transmission. So Ealing's not unique in terms of the uptake of breast screening, and there is a recovery plan right across London to try and improve that. The other thing to note is that breast screening, women get invited for their first mammogram between the age of 50 and 53. It works in what we call a round plan process. So it's based on the registered population of those women in practices. And so it works over an 18-month cycle, so that if a woman, so each practice is those women in those practices are invited in a sequential way. So it's not like bowel where you can get the kit whenever you like. You can't have your breast screen and mammogram whenever you like. It has to be in this sequential way, and you have to be invited to then be able to have the actual mammogram. Women can't just ring up and say, you know, I'm 52, I've not been called up yet. Can I have a mammogram? It's not until they've been invited through that sequential round plan process that they actually then are able to have that. So it's very different and very unique in that respect. And hence we have seen the significant drop. That's not related to the system, it's related to the fact that the suspension really put us in a difficult position, which we're now trying to recover from.
That's really helpful, thank you. And I do think it's useful to have this item because I think moving forward we can, as you say, do a deeper dive into some of the reasons and bring that back with some potential for kind of bringing forward some of the colleagues at NHS England that the panel might have questions for. But any other thoughts from colleagues around the table? Councillor Conti.
I guess the other thing with bowel screening is it's much easier, isn't it? It comes to your home in an envelope. It's not an invasive thing. You know, I know I often talk to women about going for their smear tests, and it's a very unpleasant thing for people to do. And I think the idea that when you make something much more make something easy, it's I think that's why the uptake is probably much better. But I guess it's almost like how I think it's really difficult, especially with breast screening as well. I think that how it's communicated. So because you can't just ring up every time, and do people always check their posts? You live in a block of flats, the post trays at the in maybe even another building, and people now don't get much post, they don't check it. So it's how we communicate that. And also we talk about deprivation, people on shift work, are the appointment times and the locations really convenient for people? Do they do it weekend? I don't know, do they do it weekends or evenings, or is it just Monday to Friday 9 till 5? Because I think if the service isn't modeled around sort of a 7-day-a-week service, then that's going to be much more difficult as well. I don't know what the sort of opening times are for those services, but I guess that's something else maybe to look at. But I think you're saying it's all done by NHS England, so we don't, I guess locally there's no say on how those services operate.
Oh, just use your microphone. Sorry, Raj.
From a borough-based partnership perspective and from a public health perspective, we've got the RM partners as well. There are specific posts that they've recruited, like health improvement specialists, that are supposed to be increasing uptake locally. So from a local authority perspective, we would probably help with like the data aspects and help with engaging with our local communities. That kind of inequalities part we would probably support with more so. So we do have a role in it, but not the commissioning role. Yeah.
Anna.
Yeah, thank you. I think it's and they haven't BJ, correct me on this, but unless there's some massive specific issue, we can't influence the delivery of the services. It's much more about the engagement side. And I think, like you were saying, the kind of cultural competence side, the accessibility, there's things we can definitely feedback, and obviously Health Watch have a role in that as well. So between us all, there's definitely a partnership, but we can't tell someone how to deliver their service. So yeah, and there's always challenges with complex partnerships like that, but it sounds like with the new board that's moving in the right direction. But I think they're really valid questions, Councillor Conti, so they're definitely ones we can kind of put into a bit of a plan, thinking about when we bring this back.
That's brilliant. Dr. Taylor.
Yeah, just a final point around cervical screening. The ICB certainly recently has been looking at how we can try and improve the uptake, and our borough professional leads across Northwest London have been supporting those practices right across Northwest London who are below 50%. And in fact, Ealing practices are the best in terms of Northwest London. We only had 2 practices that were below 50% uptake. And now the ICB are now looking at those practices which are below 60% now, to give them that extra support in trying to get that uptake up. So, we are continuing always trying to do what we can in terms of improving the uptake of cervical screening and bowel and breast. And we do know that, these screening programs, do save lives. Early detection of cancer can lead to potential 100% cure rate if it's caught early enough.
And it might be that I'm just thinking about the joint health overview and scrutiny on the Northwest London level, that we actually want to kind of pick up that issue to understand, because it sounds like we've got a really positive story to kind of tell in Ealing in terms of cervical screening, but there might be some practice to share across the patch there. So I'll take that away, because we have our work planning meeting coming up for that very soon. We have a colleague, Ruby, wanted to come in online. Ruby, can you hear us?
Hi there.
Yeah.
Hi. Thanks. I just wanted to add a point, a kind of follow-on point from Vijay's and also Raj's. Just to introduce myself, my name is Ruby Baines. I'm a public health consultant at Ealing. Just to add that there is an NHS England primary care engagement plan across London on, as Vijay's kind of alluded to, on cancer screening. But just to add, support the point about us exploring this a little bit further, especially the breast cancer screening rates for Ealing, which are low.
Thank you, Ruby. Appreciate the input there. Any questions or comments from further comments from panel members on this? I do just have a question again that was sent through from Alex, Alex Cowan, and she asks, and it might be that we have to take it away because it is a detailed question, but how many wheelchair accessible mammogram machines are there in Ealing, and what happens to a wheelchair user or elderly person or persons with mobility problems who cannot physically get into the very awkward positions to enable them to have a mammogram? What other test is there that is effective and available for them? I don't know who's best placed to tackle that one. Is that you, Raj?
I'm not the best placed person to answer that, but I did find an answer for us. And someone from the team, Sophie from RM Partners, came back to me, and what she said was, I'll read out what she said if that's okay. She said there are 5 locations that are serviced by the West of London breast screening service. 4 out of 5 have wheelchair access, see below, and then there's a list of them, which is Charing Cross Hospital has wheelchair access, Heart of Hounslow Centre for Health, St Mary's Hospital, they have wheelchair access, Uxbridge Health Centre also has wheelchair access. The one that doesn't have wheelchair access is Hanwell Medical Centre. And then what she wrote as an addition to that was, ideally practices should be notifying the services if they have patients that are due for screening that require reasonable adjustments. However, patients can contact service to discuss their appointment, their requirements, and whether any extra time is needed for them.
That's really helpful, and I'm sure Alex will have noted that. So thank you to you and the team for pulling that information together. We will move on. So we're sticking with the dynamic duo, Anna and Raj. We are moving on to the immunisation uptake and delivery in Ealing item. Similar to the last one, this is to think about the sort of information that we would like moving forward with a view to doing a deeper dive. Anna, I think you're just going to provide a bit of an overview, and then we'll have questions. Is that right?
We'll go straight to Raj if that's okay.
Yeah,
Just gonna share
absolutely
the
fine.
screen.
No problem at all. Shall we just give you a second to pull it up? That's grand. No problem.
You want to start?
So yeah. So similarly to the cancer screening slides, there was a whole deck that went behind it, showing what our vaccination uptake rates were across children and adults vaccinations. And just to summarize some of that information, particularly for children's vaccination, there's a whole array of childhood vaccinations, but we've decided to focus just mainly on the DTaP, which is the diphtheria, pertussis and tetanus vaccinations, and it also includes inactivated poliovirus in that as well, and the MMR vaccination, particularly as last summer we were asked to increase uptake of polio vaccination due to what was found in our sewage works. And then obviously this year with the measles outbreaks, MMR has been a priority for us as well. So we've just decided to focus on those two. And when we look at MMR uptake, you know, across Ealing, we can see that all our vaccinations are below the 95% target that's set nationally for uptake. However, when we look at us compared to Northwest London, Ealing uptake is significantly higher among MMR compared to our partners across Northwest London. So we actually don't do too badly for MMR uptake or the DTaP uptake across Ealing. However, it's significant. It's still not significantly, but it's lower than the national average. And as you will know, there's been a lot around sort of measles outbreaks and those things locally. Ealing, we haven't actually had an outbreak of measles, have we? Which, you know, fingers crossed. So I think, you know, we are working with our local communities and groups to sort of try and increase uptake of vaccinations, particularly with those groups that are more at risk. And, you know, NHS England have commissioned some projects for the VCS sector and given out grants to the VCS sector. And we're working closely with those different VCS sector communities and groups to actually understand why there's the vaccine hesitancy and, you know, and what we can do to support that. And I think that relationship takes a bit of time to move that forwards. So if we go to the next slide, if we look at the kind of all our flu vaccinations are below their respective targets, except for 2 to 3 year olds, which are significantly lower than England. And if we look at the recent trends for flu uptake among 65 and those, we can see that there's been an increase over the last 5 years. So in terms of our kind of inequalities and local priorities, you know, again, the commissioning of the immunisations takes place through our partners in NHS England. So our kind of role in it is more that kind of inequality, supporting with the local uptake. And, you know, we do support as much as we can. We have a health protection forum, and we also attend, well, we're part of an active member of the Borough-Based Partnerships immunisation group as well, where these vaccinations are discussed in a lot of detail. So I think, you know, there's a lot happening, and I think some of these efforts are going to take time for us to move them and progress them. And it'd be helpful for this group to sort of think about how or what we would like more from all of us, really.
That's really helpful. Thanks, Anna.
Thanks, Raj. Thanks. So just to add as well, just measles is very much in the news at the moment. So just to give a brief overview here from an Ealing perspective. So we have relatively low numbers, but they are trickling through. So maybe one case every 2 or 3 weeks at the moment. But you have got Harrow that's not very far away with much higher numbers. I think the perspective from London is that you have got a higher number of vulnerable people who aren't vaccinated in terms of MMR. So even though we haven't seen the massive increase shoot up like you did in, say, Birmingham and West Midlands, we are just seeing that steady increase across London, and especially in the last kind of couple of weeks. So we are expecting this to be a kind of medium-term priority for us. I think, you know, there's an awful lot of work that we were already doing over the last few years on this. That's really ramped up over the last kind of 2, 3, 4 months across lots of partners. But it's very busy at a London level. It's quite noisy. And like Raj was saying, an awful lot of the work that's encouraging, supporting, having open discussions with families who have concerns about the vaccine and that hesitancy, they are slow conversations. So when we have had outreach teams going out in anywhere in Northwest London, you're getting maybe 2 people vaccinated a day, which is, you know, fantastic because they're families that wouldn't have otherwise got vaccinated, but it's really slow work. So it is just from our point of view, it's not a kind of immediate emergency that we're going to fix quickly. It's something that's going to grow, and it's something that we are taking, I think, the right approach in terms of that engagement with communities and working with our voluntary sector groups and our faith groups in this. But it's not a quick win. Thank you.
Thanks, Anna. So I think what we're hearing is that the position in Ealing seems better than in other parts of Northwest London, but still below the 95%. And I was just wondering, are there examples of kind of best practice elsewhere that we can draw upon you know, in terms of promotion of vaccine uptake, you know, that might be something that we can explore as a potential recommendation moving forward and come back to the panel with some information perhaps.
I did actually get a contact from one of our neighbouring boroughs as we've got good uptake. We were seen as one of the better practice ones, so that's quite interesting. But I think I'm happy to contact other places that have a higher uptake, and you know, we can do that with our colleagues locally. So yeah.
It's just that thing that there's always scope for improvement, even though we're doing well. Could we do even better and push the figures up, Anna?
Thank you. And just to add, with a lot of public health topics, and particularly immunisations, there's a really strong London network as well. And an awful lot of that for immunisations is actually growing, the work of it is actually growing out of COVID. And the kind of legacy groups in terms of the community engagement, the communications, cultural competence, everything else, and the inequalities focus. So instead of being a kind of delivery focus group, it's very much on that inequalities side. So there's always good sharing, and there's also London-wide planning across that. So there might be one borough doing something, say, with a specific community group that's then shared across London, etc. So there's more and more of that coming out, which is great. There's a couple of really nice YouTube videos with, say, Black Dads doing videos and things. So maybe there's a couple of links there we could share with Anna Marie.
That'd be great. Any questions from colleagues? Councillor Conti?
On the flu in school-age primary children that's significantly lower. I just wondered, do we know what the data, I guess, on the other end is? Do we have higher sort of A&E attendance and hospital admissions because of flu in that cohort? Do we know what the impact of that is?
We don't know, but I think we could find out, couldn't we? We could, yeah, we could definitely, you know, perhaps with our colleagues, think about that.
Yeah, you know, you obviously, Councillor, you know, there is a direct correlation between, you know, protection from influenza and potential hospital admissions for secondary complications of flu, particularly pneumonia. So yes, there is an actual direct correlation. I'm not sure whether we actually worked out what the true figures are in terms of uptake versus what happens in terms of the other spectrum of hospital admissions. But yeah, it's a useful question, but whether we able to get that information is, you know, is obviously, again, that potentially might be challenging, because I guess the information that in the secondary care record may not have that information, whether that child's had the influenza vaccine or not. They would have to then track back to the general practice GP records to find out whether that child had the flu or not. So I think there are challenges to that, trying to get that information.
The only reason I thought about it was because if there was some data, it could be an extra bit of information to help encourage parents who are reluctant to show. And it doesn't necessarily, you know, I'm not talking about it tracking each individual, but, you know, is there a broad, you know, compared to, I don't know, another borough that does better, do we have, I don't know, 10% higher admissions every winter because of flu? And you know, maybe if parents are presented with those sorts of statistics, it might sort of make them think they might, well, actually, you know, it is worth doing. I don't know. I'm just thinking, because it's so low, is there something else that we could do to demonstrate to parents the importance of it? But
Anna, did you want to come in? Yeah.
I'm not going to have a neat data answer for you. I think the numbers will be small at a borough level, so I think it is probably more useful to use just the national trends on that and share that. There are part of the measles the MMR communication campaign is about measles being a serious illness and what that means for small children. An awful lot of people won't have seen it, or have a kind of sorry, I'm sounding ageist here, but have a 1970s version that it's something everybody got and it's not that bad. So there is an awful lot of the communications around this is actually quite serious. You know, 1 in X will end up in hospital. 1 in X will have long-term implications of deaths, etc. So I think that is in the materials, and again, we can maybe share that to see if it's something that the panel wants to have a look at.
Great, thank you very much. And I think in terms of next steps on that, some exploration of best practice, notwithstanding that we do pretty good ourselves, but not being complacent with it, and also be really great to share that data, even if we've got it on a kind of national level. Grand. So if there are no other questions, I'll move on to the final item, just slightly ahead of schedule. Progress on the health and wellbeing strategy. Anna, do you need some water? No, okay, all right. We'll pass over to you then. So this report just sets out the council's key achievements during 23-24 to tackle inequalities across the borough. It's also showing how multiple council departments are helping to achieve the council's plan's strategic objective of fighting inequality. So Anna, over to you.
Thank you, Chair. So this is a brief one. You'll be pleased to know at this time. Our Health and Wellbeing Board has a statutory duty to have a strategy every few years. And we signed this off last year. There've been loads of partnership engagement, lots of community engagement on this. So something we're very positive about. Just talk you through this. I'll show you these later, but these are loads and loads of fabulous photos of people taking forward the health and wellbeing strategy in the last year. So lots of examples in here. So just wanted to remind the panel what the commitments were really briefly, and then show some examples of things that have been happening in the last year. We had 3 themes. The first one was around putting communities at the heart of everything. So this was very much about listening to our communities, having those open, ongoing conversations, building up trust, and really thinking about how we develop new models of working. Obviously, the council specifically has aims around empowering communities, but also across the Health and Wellbeing Board, really thinking about that as a partnership and really using our collective resources to empower communities to do the great work that they're doing even better. The second theme was around more of the kind of background systems and structures. So really thinking, especially in terms of things like structural racism, where are we looking at equality, diversity, inclusion in our structures, in our boards? How are we holding ourselves to account? How are we looking at what are our communities saying? What are those inequalities, and who's actually having that oversight? And really thinking about how the Health and Wellbeing Board is set up to do that really well. And the final one is around the building blocks of health. So we don't have the other building block slide, but this is really thinking about the wider determinants of health. So what else is out there in everybody's lives that's meaning that they're having better or worse outcomes in terms of health, wellbeing and inequalities. So that includes everything you can think of into housing, education opportunities, regeneration opportunities, access to services. I'm really thinking that if you take one of those blocks away, it can really, really affect your wellbeing, and inequalities obviously weaves through all of that. So that's a really big part of our strategy that's different from previous ones in terms of thinking about what's the well-being impact of those building blocks, and how, when we're making decisions about those. So for example, housing, how are we thinking about well-being in there? How are we looking at inequalities, and vice versa, and really thinking about the role of the Health and Wellbeing Board in that as well. So just thinking about the last year, we've done, there's 2 or 3 slides on this. This is really thinking about the structures and capacity in the background. So Naya and I have been doing lots of work in terms of finding bits of money to build some of this up. So for example, one example at the top is we've had various posts in the across the borough-based partnership, really focusing on the priorities of the borough-based partnership around inequalities, and really taking forward some of the strategy, some of the infrastructure work. So reviewing things like the adults partnership boards, which I think Kerry's brought here before, thinking about the Health and Wellbeing Board, how it works. So for example, last week, the week before, we had a Health and Wellbeing Board, an agenda on item on climate change, and really thinking about the impacts of that in terms of inequalities. Various different bits of work around co-design, co-production, especially how the council engages with the communities. What does that look like? And then also thinking about different platforms. So for example, we've brought here before the Health of the Borough report, and one of the discussions that came out last year around that was, where is all our inequalities data? How are we seeing it? What are the trends? So that's hopefully about to launch in the next couple of months, a platform that really brings that together, and hopefully something we can build up also with more of the qualitative side. So thinking about the community voice, what are we hearing? What's that showing us about inequalities? Where do we have that so that we can actually all access that really easily? Just going, This is not moving. That's good, isn't it? Thank you. Just thinking of a few examples of the work as well. So I think we mentioned here before that we were successful in a grant of £5 million from a National Institute of Health Research to really set up the council and its partners as a research centre. So really thinking, what's that infrastructure, what's that training, what are those partnerships to really do that, so that we can really learn together with our communities about what's working and where are those inequalities. I know Kerry's team's been doing an awful lot in terms of reablement and really thinking about improving those services. The other one on here I really wanted to mention was something called Roots and Wings. So again, through various chunks of NHS inequalities funding, and with learning and conversations with our Race Equality Commission and our Citizens Tribunal, really thinking about what resources are we putting targeted towards our Black African and Black Caribbean communities, really thinking about inequalities. And so this work is specifically partly to support those smaller community groups to carry out work that they're already doing in terms of wellbeing and health in whatever that looks like for their community, but also to build up the leadership skills in those organisations, really thinking about how we actually, where are those groups in our conversations where we're developing our action plan next year and things. So that's something that's going to kick off hopefully in September, but there's been really good work in the background on that. Oh, there's lots of boxes apparently. These were just a few examples we wanted to put. So it's not just looking at infrastructure, things back at, in the background. There's been really, really great work against our health and wellbeing strategy to help deliver it that's really already impacting on communities. So there's been various events in terms of things like diabetes and falls prevention. We've been doing an awful lot of cost of living work and really thinking about how to target that to certain communities to ensure that they know what they're eligible for. There's been an awful lot of work in terms of setting up our new town forums and engaging what those look like. Obviously a big piece of work a few months ago in terms of care leavers, thinking about what can all the different partners bring to that and what are those pledges. So just in terms of next steps, we had on Tuesday. With this week, we had a really lovely event with about 60 people. So a really mix of council, NHS officers, community voluntary services and some local residents to really think about what does our action plan for year 2 look like? What's our learning from year 1? What are still the areas that we want to work on, and really think about having a few really good joint actions. So that's something we're working on over the next 2-3 months, and had lots of conversations and still some to come. And the plan is to bring that to September. So this is obviously a 5-year strategy. Year 1 was a lot of the infrastructure, setting up, finding money for various things, and now we're much more going into the delivery phase. So really good to just get your thoughts on that. And obviously, if anybody has got some ideas for year 2 action plan, that would be great. Thank you.
I will open it up to the panel for questions. Councillor Steed.
Anna, thank you for that. I don't know if you can go back easily and quickly. Beyond me. There was just something that I missed. I must have missed, but on the penultimate slide you showed, which was called "Doing the Work," I think it was. There's a figure there on the second table, reablement service, and there's a figure down the bottom there, 300% improved efficiency in the service. Should I be asking Kerry about this rather than yes? Okay.
Yes, but we can take it away.
I just wondered what that was, but anyway.
We have got the details, so there's various versions of this. This is a summary version. So we have got more details, but I will dig them out and share them with you if that's okay, Councillor Steve.
That's fine.
Yeah, we'll take that away and make sure that you get an answer. Any further questions? There is a question from Roy Willis from the Ealing Reclaim Social Care Action Group. Roy, you have stuck with us right until the end, and thank you for that. Let me pass over to you so you can ask your question.
Yes, I'm still here. Yes, it's good of you to take this question. As I know, tonight's meeting is mostly on the health themes, but it's been very interesting. The question is related to the health and well-being report. where reference is made to three key themes: listening, leaving no one behind, and connecting health and well-being. ESCA has expressed serious concerns over the closure of Ealing Care Line and the failure of decision makers to listen to the voices of Care Line users and subscribers, thus risking leaving some of the most vulnerable residents in the borough behind in terms of their independence and safety in their homes, and also a failure to link their health and well-being, which allows them to stay in their own homes for as long as possible. Can we have a timetable for when a like-for-like service will be provided to all previous users of Ealing Care Line? Thank you.
Thanks very much, Roy. Anna, I think we're going to arrange for Kerry to provide an answer, but did you want to say anything on that one?
No, thanks, Roy. And I think it's really good that we go forward with a lot of our decisions, looking at how the health and wellbeing strategy aligns with them and is taken forward. I think it's something we've talked before, especially Health and Wellbeing Board, but even internal in the council, we think about how decisions are made about, say, the council plan, for example, but not necessarily against this. And that's something Kerry and I have discussed. So in terms of this specific query, Roy, we'll take that back to Kerry and ensure that that comes through Anna Marie as a specific response. But thank you for the point.
Thanks very much, Roy, and thanks, Anna, for that. Are there any other questions on this item? So I think we move to the final item of the agenda, which is our panel recommendations for the year. We're just asked to note the responses to the recommendations that we've made at our previous meetings. Are we happy with that? Any comments from colleagues?
Yes. Yes, we're happy with that.
Brilliant. In which case, I think so. This is the final meeting of the civic year, and our next one will be in July. So thank you very much, everyone.
Chair, you have to give me a minute, I'm afraid. It's my role as vice chair at the end of the civic year to express the thanks of all around the room and previous attendance to your first year as chair of HAS. You're already on the committee previously, of course, and your background obviously gives you some ideas to many of the topics that we covered, but you have managed to control the agendas with exemplary charm and tact to try to finish on time, which I think on the whole you've actually done very well. So you have our thanks for that. I was going to say, if nothing else, but you do have our thanks. You do have our thanks for that. So thank you very much, and we look forward to year 2.
An absolute star support and of course all colleagues that have presented to the panel, and for the